So I've just finished recording my ESTRO presentation for the virtual ESTRO 2020 conference. And the paper we're looking at today is actually the paper that's meant to be the follow-on to that abstract presentation. But because of pandemic events this year, the paper's actually been published prior to the conference taking place. So this paper, in collaboration with the University Medical Centre Groningen, particularly with Charlotte Brouwer, who I'll be talking to later on in this video, looks at the performance of auto-contouring in routine clinical practice. If we think about the sort of typical evaluation of auto-contouring, there are two standard sort of studies that are performed. The first is in the technical development phase, where the question's often asked, is it auto-contouring accurate? And to answer this question, typically a quantitative analysis is done against some kind of clinical ground truth contour, using measures such as DICE or the added path length. And we've seen an example of this in a previous video with Zhao Feng, where he looked at the performance of the system he was developing. Following technical development comes clinical commissioning, where we're asking the question is, do we expect the auto-contouring system to be useful in the clinic? And to attempt to answer this question, typically efficiency studies are done, comparing the time taken for manual contouring to the time taken to edit auto-contours to a clinically acceptable standard. And we saw an example of this in the video with Tim Lusberg, where such performance was done for a deep learning contouring system. But typically we draw the line there. That's as far as the assessment of auto-contouring performance generally goes. We make the assumption that what was done in the technical validation and the clinical commissioning is appropriate and representative of what's going to take place in the clinic. So this paper goes a little bit further and asks, well, what is the impact in the clinic? What editing is taking place in routine clinical practice? In this study, about 100 cases were taken following routine use of Murata Medical's deep learning contouring. Those patients had the edited clinical contours that were used for developing the treatment plan available. And they also had the deep learning contours that were initially used prior to editing for the patient's treatment. So given those two sets of contours, we can work out the amount of editing that's taken place in clinical practice by looking at the difference between the two contours. But to be able to compare across the 100 patients, we need to register all of these images into a common reference frame. So to do that, a average patient was selected, essentially the patient with the median volume, for each organ. Rather than using image registration, which is going to be dependent on how well the images look similar to each other, a mesh-based registration was performed. Now, to explain this is somewhat technically complicated and perhaps beyond the scope of this video, where we're trying to really look more at the clinical meaning behind this evaluation. Hopefully I will find time to record a more technical explanation, in which case I will post details of that video in the description for this one. So having registered everything into a common reference frame, it's possible to get that degree of editing in a space for all the patients, and then be able to perform a comparison of where that editing is taking place. Generally with figures, the more information you include in the figure, the harder it is to interpret. Conversely, the less information you put in, the less there is to glean from the figure. This is figure 2 from the paper, where we look at the range and the median amount of editing for each of the different organs. On this figure you'll see two vertical dashed lines representing 2 millimeters additional subtraction from the contour. And this was taken to be representative of inter-observer variability, sort of the amount you might expect contours to vary just from two different people drawing that same contour. And what this figure shows us is, while the median amount of editing generally falls within the intra-observer variability, there are points at which the contours are edited which exceed that. The range goes outside of those boundaries for the majority of organs. But this figure can't tell us how often that occurs or where that occurs. Figure 3 in the paper gives us a little bit more information. This looks at the histogram of the amount of editing taking place. We can see from these histograms actually the majority of edits being performed in the clinical routine are less than 2 millimeters. There are, however, some cases, as we saw in the original figure, where more substantial editing is taking place. This tells us effectively the proportion of those larger edits, but again, it doesn't tell us, give any indication about where those edits are taking place. Are they randomly distributed or systematic? To understand that, we have to look at the visual representations provided in figure 1 in the paper. On the left-hand version of each organ, we're shown the median amount of editing over all 103 patients, and the right-hand figure for each organ shows the range of editing. Let's take the example of the parotid to better understand that. The arrow now points out where an area which is green, representing a median of effectively no editing. So in this part of the parotid, very little editing is taken on average across the whole of the patient population. Whereas the tail of the parotid that extends along the mandible we see is dark red, representing an expansion. And we see here that a substantial amount of editing is happening on average over all 103 patients. But how variable is that amount of editing? If we look at the range image, the blue represents very little variation between the amount of editing over those 103 patients. So that part of the parotid, not only is very little editing happening, there's very little variation in how much editing is happening. So it's consistently not edited for all patients. Whereas for that tail that extends, we see high variability, which suggests for some patients a lot of editing is being performed, but for other patients very little editing is actually needed. These figures are hard to interpret, and as we'll see in the interview with Charlotte, they introduce the challenge of, is this a difference in the degree of editing because of the performance of deep learning in clinical practice, or is it a difference in the degree of editing because of variations in the technical team doing that editing? Are different dosimetrists making different decisions? Is this actually representing inter-observer variability? Let's look now at the interview with Charlotte and get her understanding of what this paper showed.
Hi Charlotte, thanks for joining me today. It's going to be interesting to talk about the paper which we worked on together actually on looking at analysing the performance of auto-contouring in clinical practice sort of retrospectively. Start off with, why don't you just give a quick introduction, who you are, where you're working, what you're working on.
Yes, so my name is Charlotte Brouwer. I work as a medical physicist in the University Medical Center Groningen in the Netherlands. And currently one of my clinical interests is proton therapy, but also one of my largest interests is contouring, so both clinic and research. So it's a pleasure to be in this interview.
That's right, and I think with your interest in contouring, you've been first author on the head and neck OAR guidelines as well. So very much keen to make sure contouring is right in clinical practice. So in this study, we retrospectively analysed the editing of auto contours that have been used then subsequently for clinical practice. Why do you think it's necessary to perform this kind of analysis if the system's already been commissioned?
Yeah, I think it's important to present this as one of the tools that we can use in the monitoring of the deployment of the deep learning model or of any contouring model. And I think, you can have two purposes of this kind of evaluation. So first, you can monitor the behavior of the system in the clinic, but also the behavior of the staff. So yeah, the system, of course, in this paper, we looked at systematic edits. And if we find for some organs that the areas are systematically edited, then of course we have some direction to look for further improve our contouring model.
Yeah, so we saw that with the mandible in this particular study, where there was a bit that was consistently missed, and then we're able to improve the auto contouring there.
Yes, so it's a combination of the model and how you implement the model. Because for the mandible, we found that in the post-processing we made a slight misunderstanding, and that was the reason that one of the parts of the contour was cut from the end result. So that was something that we could fix after.
Yeah, so the AI contouring was working, and during commissioning it had been seen to be working, and then when it got implemented, it was implemented slightly differently and chopped off a bit.
Yeah, and also because not all mandibles have the same shape and appearance,
yeah.
So that's why. Yeah.
And then on the clinical side, you can also look at the performance of your clinical team. How does that work?
Yeah, exactly. Then we can actually study how the clinical team is making the edits to the contours, and if they do it in a consistent way, or if they have differences in interpreting the contouring guidelines still. So, for example, for the pharyngeal constrictors, we also found that the staff is doing different amounts of edits on the anterior side, and yeah, it actually resulted in a nice discussion within our team as to how we want to do this in clinic. There's always a balance between contouring the organ that you see and be consistent in the way you contour. So I think at the end it's interesting.
So I guess it's quite interesting.
Sorry?
It's interesting then that by doing the study, you've prompted internal discussion to sort of highlight the need for consistency. And in a way, it's not the findings of the study that necessarily does that, but the fact that you've done the study in the first place.
Yeah, actually, it was not the purpose in the first place, but now it serves as a nice tool for the contouring meetings, the evaluation meetings, and training for new staff. In our hospital, we do have a very small group of RTTs who are expert in head and neck. Also because within our center, we developed all the guidelines, etc. But if you will apply it to a larger group of staff editing the contours, it's even more interesting, I think, to study the behavior of the edits that are being made.
So what do you think the most important takeaway that you got from doing this study was?
Yeah, for me it was like, I found that it's still hard to know the real contour and to find a reason for a contour being right or wrong or being edited actually. So I think you can finally lead this to three different reasons. So first, the deep learning model itself. Maybe there's something that we can improve on it, that is misinterpreting or misclassifying. It can also be that it's because of the input data, that your input data is slightly different and therefore causing a wrong output. Or the staff itself, so the user correcting it in a different way than it's meant to be. So.
And then with the user, we've got the challenge of just a subtle difference in interpretation, inter-observer variability, or the question of whether they've misunderstood the guidelines. Which,
so we started studying. Yes, I thought it's easy. We will definitely find regions where we have systematic edits, but at the same time, we found a large variability as well. Yeah, for one reason, it's because of the patients, and all organs have different shapes for different patients, of course, and that can be a reason for the contouring tool not predicting that accurate. At the same time, we had to really go into the individual patients and discuss what went wrong. Was it because of the DLC prediction or because of different interpretation? Yeah, so that I think it's very interesting of this paper.
Yeah, no, one bit I took out of it, which I retrospectively kind of made sense, but I hadn't really thought about, was particularly with the spinal cord, how you interpret the guidelines, or where the guidelines have almost options. You know, you should contour down to a certain point on the spinal cord, unless the tumor's lower than that, in which case you contour further, which then looks like high variability, but potentially that's because of the tumor location, and essentially the guidelines have some flexibility in there that you can't, you know, unless an AI algorithm knew where the tumor was, it wouldn't be able to implement that part of the guideline.
Yeah, exactly. And it's also because of the order in the process. And first, the organs at risk are contoured, and after the tumor. So because the staff didn't know the tumor location, sometimes they just draw it all the way to the caudal side to be sure it's included. But for 99% of the patients, the initial prediction is good enough. So now we make sure that they have the check after the target contour, and then only edit if necessary. So yeah, that's what we do.
So I found figure 3 with the different histograms particularly interesting, because what that revealed was that actually the vast majority of edits are within this sort of 2 millimeter range of the actual contour. You know, there are obvious errors or obvious edits where, you know, it may be even up to 10 millimeters needs correcting. But yeah, there was 90% or so within this sort of 2 millimeter range. Whereas I guess mentally I'm thinking either somebody's going to fix it because it was significantly wrong, or they're not going to bother touching it because it's close enough. You know, this suggests that there's a lot of minor tweaking going on. Do you think that's an artifact of our analysis, or do you think this is somebody's, the clinical editing behavior? And do you think that kind of level of editing is clinically significant?
Yeah, I think there are two reasons that it's showing this large amount of small edits. So yeah, indeed, the staff is working very accurate and is correcting all the voxels that they see that is wrong according to their view. But also for some organs, we did output the deep learning contouring with an interpolation, slice interpolation. And then when loading the contours in our planning system and do this interpolation of the structures, it can also cause a slight change in structure within a millimeter, which is different from the interpolation in the Mirada system. So I think this is one explanation for the very small edits. But yeah, the first explanation, the staff itself. I think this analysis opened their eyes that they see, okay, it actually doesn't make any change for my radiotherapy plan if I do edit these small amounts of changes. And because nowadays we plan normally on average dose to these structures. So you can say, okay, we can accept small contouring errors. And but for the future, of course, we don't know if the average dose is still or is it actually the leading thing that leads to the toxicities that we are watching. So for clinic and research, you can separate the application of this contouring accuracy. So, but after discussing all the results, the staff concluded, okay, for the structures that we can see in this histograms, but also in the other figure, which is showing the median and the 10 and 90 percentile.
Yep, the 3D plots, figure 1.
Figure 3 and figure 2. So for example, for the brain structures and the mandible, they can just go ahead with a quick check and only correct the real outliers, because there can be some outliers, but 80% of the data is correct as it is. Yeah. This is now one efficiency gain that we go on.
Yeah, I guess, I mean, it only kind of dawned on me, even in this conversation, that actually the process of taking the auto contouring out of the Mirada system, and then you load it into RaySearch, and as you say, you've done this slice interpolation workflow. Yeah, even if you took the contours out of one system, loaded them to the other, and then saved them out again without even touching them, there's potential for some differences just because of loading, saving, internal representations, etc.
Yeah, exactly. So it makes the users aware of this, intrinsic, accuracy of contours.
Yeah. But
also the inter-observer study, of course, they have seen the differences between each other, and this is also in the same order, 2 millimeter units.
So I'm going to wrap up with one last question. Why should somebody go away and read this paper?
Well, in the first place, the paper has very nice pictures, of course, this presentation. And I think it's what I said in the beginning, it's important to have people aware of this tool for both commissioning, to be able to evaluate the performance of the model, but also the editing in clinic.
Yeah, I was really excited in doing this study because there's swathes of papers which talk about the commissioning process, and then you kind of don't know what happens afterwards. And actually, this is a great example of a system's been in place for 1 year, it's been used on lots of patients. Let's now look at really what's going on, as opposed to what might go on in the future if we implemented it. And it's definitely a shift in mindset in this paper.
Yes, exactly.
Well, thanks for discussing it with me today. Hopefully we'll be able to take this work further forward and start to look at maybe dose and the clinical impact around some of these edits.
Yes, thanks a lot. It's my pleasure.
I got as far as editing the video and realised that I took the Charlotte for so long, and now I'm going to have to record a very concise conclusion. The discussion I was going to have at the end was around how this study is different to those of commissioning studies. What do we see? And I think one of the key factors is that we see a difference in behaviour because we're sampling the entire patient population and we're not investigating people in an artificial setting. We're looking at actual performance in clinical routine. I'd advocate you go away and take a look at this paper. As Charlotte said, it's got pretty pictures. Thanks for listening. If I do get around to recording a more detailed technical video, I will include that in the comments, in the description of this video. But until then, thank you for joining me, and I hope you'll come back to the auto contouring review on another occasion.